Welcome to today's webinar on emerging trends in the screening and diagnosis of autoimmune diseases, organized by Voice of Healthcare and supported by Agilus Diagnostics and Sebia. Autoimmune diseases pose unique diagnostic challenges. They deeply affect patients' lives with complex symptoms and barrier to accurate diagnosis. As we delve into today's session, our esteemed panel will guide us through emerging technologies, diagnostic methodologies, and innovative approaches that are shaping the landscape. Together, we'll look at the promise these trends hold for improving diagnostic accuracy and ultimately patient outcomes. We are fortunate to have experts joining us who bring diverse experiences and perspectives. Our speakers today are Dr. Deepak Sanghavi, Vice President Operations, Chief of Mumbai Reference Lab, Agilus Diagnostics. Welcome, Dr. Deepak. Dr. Siddhartha Sharma, Head Clinical and Scientific Affairs, Sebia, India. Welcome, Dr. Siddhartha.
Thank you, Dr. Manisha.
Dr. B.G. Dharmanan, Consultant Rheumatologist, Manipal Hospital, Bangalore. Welcome, Dr. Dharmanan.
Hello.
Dr. Shalja Sebnes, Consultant Physician and Rheumatologist, Nanavati Back Super Speciality Hospital and Holy Spirit Hospital. Welcome, Dr. Shalja.
Good evening, everyone.
I, Dr. Manisha Khurana, on behalf of Voice of Healthcare, thank you all for being here. So it's my pleasure to invite Dr. Deepak to present on advances in automation and multi-analyte platforms in autoimmune diseases diagnosis. Dr. Deepak, over to you.
Thank you, Dr. Manisha, for the kind introduction. I will request Nitin or Katharine to present the slides. So good evening, everybody. So today what we are going to learn or discuss is the topic of how autoimmune disease diagnosis algorithms are there, what innovations we have done as a lab, how do we optimize the diagnostic solutions, and overall perspective about autoimmunity disorders. So there are four different types of autoimmunity disorders where we are talking about organ-specific and systemic disorders, different testing platforms, different diagnostic guidelines and algorithms based on the guidelines, and what is our laboratory role to help the clinicians to reach better diagnosis in autoimmunity. Next slide. So just a basic definition, we all know that autoimmunity is basically an inappropriate response of the immune system. We have to know that it involves various organs and tissues that we can see it is as multiple organs are involved because of the antigens, single antigen or multiple antigens involved in autoimmune disease. It is basically a damage or tissue injury which is caused by the humoral antibodies, that is autoantibodies, or cell-mediated immune response. Here we are talking about reactive T cells for self-antigens. So our own antigens are getting destroyed because of the response by the because of the condition autoimmunity. Next slide. Just a prevalence as per the many articles that are present in the literature, 3 to 4% of the population is affected by autoimmune diseases. There are 80 different types of autoimmune diseases which are differentiated as systemic as well as tissue specific, that is organ specific. Some common examples we all know is SLE, diabetes mellitus, autoimmune hepatitis, rheumatoid arthritis, which is commonly seen, thyroiditis, psoriasis, Crohn's disease. And the prevalence is higher in women as based on many articles. Next slide. And we see the incidence rate of different syndromes. Some syndromes, the incidence is more in females, and some syndromes, it is more or equal in males also. Next slide. This is a table where we are talking about different autoimmune organs which are involved. So we are talking about the primary target organ which is involved in autoimmunity, whether damage is happening by the autoantibodies or against the self-antigens. Especially the organs that we are listing here is the skin organ, where we are having disorders like psoriasis, pemphigus vulgaris, the central nervous system involvement by optic nerve or the spinal cord or the nerve tissue, where multiple sclerosis, neuromyelitis optica is the disorders we are talking about. The involvement of endocrine organs like pancreas, where we talk about type 1 diabetes, thyroid when we talk about the Graves' disease or hyperthyroidism, or Hashimoto's disease, and other Sjogren's syndrome if the salivary glands are involved. Next slide. Some more organs which are also involved in autoimmune conditions are the kidneys, where we talk about lupus nephritis or Goodpasture syndrome. In joint involvement, we are talking about the proximal joint involved or the distal joint involved, where we are talking about rheumatoid arthritis, psoriatic arthritis, and other kinds of arthritis. The muscle involvement, where we talk about myasthenia gravis or polymyositis, and reproductive organ involvement, where we are talking about oophorytis or orchitis. So basically, this the prevalence is variable in different organs. Different organs are involved. The symptoms are also different, but because of the complex or multiple organ involvement, the symptoms may be overlapping. And the mechanism is basically the autoantibodies against specific antigens that we all have to know about. Next slide. More organ that is we all know about the GI tract, where we talk about small intestine, liver, the stomach, where the disorders which where we are commonly have to know is Crohn's disease, ulcerative colitis, celiac disease, primary biliary cholangitis, autoimmune hepatitis. So prevalence is again different for different disorders and different mechanisms for involvement. Next slide. So, yeah, as we have seen that there is a multiple organ involvement, multiple kinds of symptoms overlap will happen, and this makes it challenging. And that is what clinicians, as per their experience, diagnose the disease. They send the test for helping the diagnosis. But we all have to know that these antibodies which are sent for testing are having variable kind of exposure based on the level of antibodies and the level of the disorder. Plus, because of the treatment or other kind of therapies which are used, there could be a possibility of false negative or inconclusive test results in antibodies also. And that is what we are going to learn in today's presentation. Definitely, many patients come with a delayed diagnosis, and hence disease becomes progress at a higher level. And we all have to make aware about the autoimmune disorders for early diagnosis so that the patients can be treated early. Next slide. And we have a list of many markers for different autoimmune disorders which we have to learn as a laboratory. For rheumatoid arthritis, we talk about CCP, rheumatoid factor, and MCV antibodies, that is a vimentin antibodies. In ANCA, when it comes to ANCA, we are talking about PR3, MPO, GBM, cathepsin. When we talk about connective tissue disorders, there's a big list of antibodies that we have to know of. First is the ANA screening, and then dsDNA, RNP70 antibodies, centromere antibodies, Jovan antibodies. In thyroid, we are talking about anti-thyroglobulin antibodies and calprotectin kind of testing. Next slide. When it comes to gastroenterologist, there are multiple again antibodies, anti-mitochondrial antibodies, parietal cell antibodies, intrinsic factor antibodies, tissue transglutaminase antibodies, gliadin antibodies. When it comes to antiphospholipid syndrome, we have to know that cardiolipid antibodies are there, phospholipid antibodies, beta-2-glycoprotein antibodies. Next slide. And then we have a special big list of autoimmune disorders and a big list of autoimmune tests which are available. We all have to know that, as I have told, the test also testing reports are also coming overlapping because of this cross many organs involved. And as you can see here, the dark blue are the antibodies which are basically specific for those disorders, and the light blue are basically seen in those disorders but not specific as per the guidelines. But these antibodies are overlapping in multiple disorders and multiple antibodies. This is what I want to show in this slide. Next slide. And again, one more table to demonstrate that if you go antibody wise also, like classical antibody like CCP, which is commonly used for rheumatoid arthritis, may also be happening or positive in Sjogren syndrome. So such kind of lists are available which you can read the textbooks or go to literature and find out which antibody can overlap in which condition, and hence can reach the further diagnosis. Next slide. So now I will come to the laboratory's role in autoimmune diagnostics. So we are talking about autoimmune testing technologies, what all is available. So basically, an history and physical examination helps to find out which platform, which test is needed for which specific autoimmune disorder. So commonly we as a laboratory, we have multiple sections, right? So when we talk about sections, we have common test screening for CBC, ESR. Then we come to bone marrow for the diagnosis of ITP. Or examples in biochemistry testing platforms, there are tests like RA, CRP, which are commonly prescribed. There are complement C3, C4. There are cytokine testing, which is required. Similarly, in immunoassay platform, which is antigen antibody reaction platforms, there are multiple names of these platforms, which are called as ELISA, which is commonly used. Fluorescent enzyme immunoassay, which is also commonly used. Chemiluminescence platforms. Now, the new technologies which Dr. Siddhartha will take in detail is SMC ELISA platform, and a multiplex bead assay also, where multiple antibodies can be detected together. Similarly, there are more platforms, especially flow cytometry based, where you are talking about T and B cell diagnosis. Also, HLA is also one of the common important platforms for in one of the workup for autoimmune disorders, where we talk about HLA by doing PCR or NGS methods, the next gen sequencing. And we all have to know it's a common platform for autoimmune diagnosis is the ANA or ANCA or dsDNA, which is done by indirect immunofluorescence and immunoblot methods, which I will be taking little bit in detail in further slides. There are tissue-based diagnosis also, which are called as direct immunofluorescence methods and imaging techniques. So all these platforms or different methodologies are available to help clinicians reach the diagnosis for autoimmune disorders. So we are summarizing that till now we have multiple antibodies, multiple organs, multiple testing platforms, and multiple tests related to autoimmune diagnosis. Next slide. Next slide. So how do we get the correct SOP for finding out which how to go about their autoimmune disorders? So definitely there are good guidelines which are giving us this guidance of how to handle this complex testing procedures. So like American College of Rheumatology guidelines, ACR guidelines for rheumatoid arthritis, psoriatic arthritis, lupus arthritis, it gives a very good approach to the diagnosis. We have European League Against Rheumatism, that is EULAR guidelines for lupus and rheumatoid arthritis. There are Crohn's and Colitis Foundation guidelines for Crohn's disease, definitely. There is American Thyroid Association guidelines for helping in Hashimoto's thyroiditis and Graves' disease. Next slide. There is American Academy of Dermatology guidelines, which helps in psoriasis and dermatomyositis diagnosis, vitiligo diagnosis. National Institute for Health and Care Excellence, NICE guidelines, helping in lupus and multiple sclerosis. There are also specific multiple sclerosis society guidelines, which helps in management as well as finding out resources for multiple sclerosis. Sjogren's syndrome foundation guidelines also available for Sjogren's syndrome, and lupus foundation America guidelines are also available. Next slide. So coming down to how when we read the guidelines, there are proper exact criteria given by those guidelines to diagnose a specific disorder, which includes specific antibodies for that disorder, which includes this overlapping or helping markers for the diagnosis, which may or may not be specific. Your classical example is the EULAR or ACR guidelines talking about use of dsDNA and Smith antibody for diagnosis of SLE, which are called as SLE specific antibodies. But there are additional antibodies which are helpful in diagnosis, and the weightage is given as, even the weightage of marks are given by the guidelines. Like in this case, cardiolipin and beta-2 glycoprotein and lupus anticoagulant also are important tests to be done in SLE diagnosis. Next slide. So these guidelines also talk about using ANA IFA, indirect immunofluorescence, as a primary screening methodology, kind of a gold standard. And then based on the ANA IFA screening results, further testing, or we call it as a sequential or a reflex testing algorithm, which clinicians follow, and as a lab we have to know that these are the further testing tests that needs to be done to get to a diagnosis. For example, after ANA is positive, the test which can be done is dsDNA, SM antibodies or ribosomal antibodies for helping in SLE diagnosis. For drug-induced lupus, histone antibodies. For Sjogren's syndrome, SSA, SSB antibodies. For systemic scleroderma, SCL70 antibodies. For mixed connective tissue disorders, UNSN and RNP antibodies. For CREST syndrome, centromere antibodies. And for polymyositis, dermatomyositis, Jovan antibodies. So there are multiple antibodies which will give you a specific diagnosis. And there are multiple platforms. For example, the same list of antibodies which I have shown in this flowchart can be done by an ELISA platform, can be done by an immunoblot platform, can be in ELISA also there is a single well manual ELISA platform and automated platforms, and some of the antibodies can also be done by CLIA platform. So same antibodies, multiple platforms are available. The sensitivity and specificity of each of these antibodies on different platform is also different. So we have to see the guidelines, we have to read literature, we have to have our own experience of which platform will help to diagnose the specific antibody. Hence, the diagnosis can become important for the clinician. Next slide. Similarly, antiphospholipid syndrome also clearly defined laboratory criteria are established, where we talk about IgG, IgM, beta glycoprotein antibodies, cardiolipin antibodies, lupus testing, and all these will help to reach a diagnosis for phospholipid syndrome. See, again, the cardiolipin or beta-2 glycoprotein, the platforms available are CLIA platform, ELISA platform, Autoimmunity ELISA, automated ELISA platforms. For lupus, you have basically the coagulation platforms. So multiple platforms to detect the same kind of antibodies. Next slide. In ANCA also, for diagnosis of vasculitis, you have basically on the immunofluorescence, you have to check for C ANCA or the P ANCA, that is a peripheral ANCA, as well as the same things can also be done by an ELISA platform. Like C ANCA corresponding antigen we have to know is anti-PR3, and for P ANCA it is anti-MPO. So based on either you can use an ANCA IFA for screening or directly go for a PR3 MPO ELISA antibodies also for diagnosis. There is sensitivity specificity is more or less equal or little more in the ANCA platform in the sensitivity front for for the vasculitis diagnosis. Next slide. There is select disease algorithm where we talk about screening by TTG, IgA antibodies. Then based on this algorithm says that you have to go for TTG, IgG antibodies when IgA or IgG is given, DGP antibodies, that is deamidated gliadin proteins, or endomycin antibodies. And finally, biopsy as one of the diagnosis helping for select disease. So all these different tests will help to reach the diagnostic and properly clearly defined diagnostic algorithms are mentioned in the guidelines. Next slide. So next, coming to how these platforms look and what are the things that we as a laboratory do to help faster diagnosis, accurate diagnosis. Next slide. So we have platforms, automated ELISA platforms, which is called as SMC ELISA, which will be detailed discussion by Dr. Siddhartha. We have immunoblots. So this kind of a basically nitrocellulose paper where multiple antigens are coated, and basic serum sample is required. Very small quantity sample is required. You just put it on the strip. There is a procedure of like in SMC ELISA, approximately 1 hour. In immunoblot, it will take around 2 hours. For fluorescent enzyme immunoassay normally takes 90 minutes, and automated ELISA takes around 3 hours. So you can actually do a reporting on the same day for autoimmune antibodies to help faster diagnosis and accurate diagnosis for the clinicians. Next slide. And for the IFA, you have now automations available where bidirectional interface, you just load the serum sample, the machine does the processing, all IFA slides are prepared automatically. These slides can now be seen under the microscope in a dark room, and based on the patterns you can do the diagnosis, and that is what is reported on the reports in a proper with a titer form, either given in a titer or a pattern, and positive and negative. You have automated platforms for immunoblots also, and now we have the digital IFA platforms to actually scan the images, do an automated reporting, and show the images to the clinicians also, so that they are aware of what further diagnosis they are going to do. Next slide. So these are the patterns which you see under the microscope, which are like you are seeing a nucleus in a hepatocyte cell, and you see the pattern as homogeneous or a membrane pattern or granular pattern, dotted pattern. Next slide. So we all have to remember now that there are international consensus on even reporting of ANA patterns. So multiple kind of proper guideline is given of what is the actual reporting, better format of reporting of ANA, which as a lab when we follow, this is going to become standardized across the world. Next slide. So similarly, dsDNA, as you can see, there are multiple platforms for doing dsDNA diagnosis also. You have immunofluorescence, which I have shown it in the picture here. You have ELISA, which is called as dsDNA NCX ELISA. You have FAR assay, which is used to be done by an RI method. And nowadays you have dsDNA by, as a long time also, by a blot method. So you have 4 platforms to diagnose dsDNA. We all have to know there are different sensitivity. Again, I'm repeating, dsDNA by an IFA is specificity is 100%, but the sensitivity is only 30%. While ELISA will have a sensitivity of 70% and specificity of 90%. While the NCX ELISA will have further sensitivity, and blot will have a lower sensitivity and specificity. So based on that, we have to decide which platform is going to help the clinician have reach a better diagnosis. Next slide. You have the centromere pattern. Also can be detected by an ELISA, centromere ELISA, or an IFA. You can see a clear-cut pattern. Next slide. There are cytoplasmic filamentous patterns also for actin, vimentin, and tropomyosin, which helps for further diagnosis, especially the liver autoimmune hepatitis. Next slide. So these are the report formats. I just have populated here to show you that in an ANA, you are actually reporting the whether it is positive or a negative. You actually give an intensity 1+ to 4+ to help the clinician know how intense, how stronger the report, the intensity is. You are actually giving a pattern which is kind of a speckled or homogeneous pattern. And an endpoint titer, you do dilutions starting from 1:100 up to 1:3200 to help clinicians find out how strong the disorder is and how better the correlation of that antibody will happen with the disorder. We also give a chart report to explain how this ANA can be further worked up by different antibodies. Next slide. Similarly, an ANA blot report where multiple antigens will be shown in the same report, positive, negative, intensity, all this will be reported in a blot. You have actually 18 antigens reported together in one strip. And we also have given a chart where how overlapping antibodies can be seen, and which helps the clinician to diagnose it further. If you find in the blot some antibodies and you want to confirm it, there are single well ELISAs available for each of these antibodies, which helps to confirm a report of ANA blot. Next slide. Similarly, in ANCA report of the immunofluorescence, next slide. And an ELISA NCOPAG report where we give a quantitative value with a reference range so that the clinician can understand that the value of the report, and it can be helpful for monitoring purposes also. Next slide. So what are the new initiatives or innovations that now lab is doing? So there are digital units available where all the microscopy that a lab is doing can be scanned, can be shown to the clinician, can be shared with the patient, so that this, because it's a final report and it can help the doctor to continuously monitor the patient. As well as there are now automated platforms which are available, which reports in 1 hour, maybe 45 minutes for faster diagnosis, and helps in very critical conditions the patients can get faster reports. Next slide. So what as a lab we are doing, we are trying to create a center of excellence for reporting for important autoimmune conditions. We interact with the specialists like rheumatologists, immunologists, dermatologists to understand how we can help them in their diagnosis. For definitely we as a lab have to maintain a good quality. So we participate in ICAS programs, and where we all have to have 100% score so that clinician is very sure about the reports. We have to have integrated digital reporting also, so that the clinician is actually seeing evidence-based reporting and diagnosis. So we all have to collaborate for this complex autoimmune disease diagnosis and help the patients reach the goal of having a better life. Thanks from my side.
Thank you, Dr. Deepak, for invaluable insights. And I'm sure that if we do the multi-analyte on various platforms, depending on their sensitivity and how the clinician guide us, we will definitely transform diagnostic industry. So now I would like to invite Dr. Siddhartha to present on autoimmunity testing simplified advantages of ELISA monotest technology.
Yeah. Thank you, Dr. Manisha, and thank you, Dr. Deepak, for such a lucid presentation which encompassed and simplified actually such a vast diagnostic spectrum, vast clinical and diagnostic spectrum of the autoimmunity disease. I know it's a very complex disease, and to have a proper laboratory technology to actually sort of pick the relevant biomarkers is a challenge. So you need to have a good laboratory autoimmunologist and a good clinical autoimmunologist to actually help the patient. So that was a very wonderful talk, and thank you so much. So I would request Katyayani to please share my presentation, and I can start with the same. So thank you everyone for joining in. And the topic of my presentation is Autoimmunity Testing Simplified, Advantages of a Monotest Technology and a Broad Portfolio. So just to take from where Dr. Deepak also amplified in his presentation, autoimmune diseases are challenging to diagnose and to treat. They can affect any organ system and have many symptoms in common. So therefore, they are very complex and very difficult to diagnose. Also, importantly, what a laboratorian and a clinician should understand and know is they may progress rapidly or fluctuate between flare-ups and phases of inactivity. So the timing of the test for autoimmunity disease is quite important, because that can lead to a lot of variations in the antibody levels, whether it has been sent at the time of a flare-up or at the time of inactivity, or what we call as a quiescent phase. They often come along with secondary autoimmune disorders and can lead to development of other antibodies apart from the primary autoantibodies which exist, and also can be treated effectively if detected early. So early detection is quite important for any autoimmune disorder. So that lot of therapies are evolving now, with biologics also coming into play in the therapeutic space. So definitely pinpointed precision therapy is available for autoimmune disorders. All the more laboratory diagnostics has a very relevant role to play. So Sebia has made an attempt to, or rather brought a solution in simplifying the complexity of autoimmune diagnostic space. So we have a patented Allegria Monotest technology. So Allegria is the name of the instrument, and Monotest technology is the technology which the instrument uses. So Sebia has been known to provide Allegria Monotests for autoimmune and infectious diseases for more than 15 years now. We have an extensive assay portfolio with more than 85 Allegria monotests currently available, and more than 110 tests are planned for the year 2024. So that it will bring about quite an exhaustive menu for autoimmune testing. And consistent analysis is possible with processing of serum, plasma, and stool samples. And interestingly, all the samples can be processed simultaneously, which I would be detailing in my subsequent slides. A flexible combination of Allegria monotesting is available, and that is of very good utility to any laboratory performing autoimmunity testing on this platform. And this all leads to generation of a comprehensive patient-oriented diagnostic profile. So with the exhaustive diagnostic disease-specific profiles available, it leads to a generation of a good patient-oriented diagnosis. So this is what Allegria is. It is an enabler of Organ Tech, and Organ Tech was the company which was acquired by Sebia, and it's a very well-known organization in the autoimmunity segment, and they were actually the developers of this monotest strip technology. So the uniqueness or the unique value proposition of Allegria is, and here when I say Allegria, I'm talking of the semi-automated instrument, that is Allegria 1. We also have an fully automated instrument, Allegria 2. I would be talking about the comparisons, or rather showing the comparisons later on. But in Allegria 1, it offers a maximum flexibility. So using a one strip, one test principle, or a laboratory can have a processing of 30 samples, rather 30 combinations in one run. So in one go, you can process 30 different tests, or the 30 same tests, or each test of 30 different patients. So the amount of flexibility offered for autoimmunity testing, considering that any lab at any given point in a day gets different samples of autoimmunity testing, this is adding to the value of the laboratory processing of autoimmunity samples. Also, we have ready-to-use reagents which are pre-filled in the Allegria monotest strip. So if you see the background, you can see the strips which are pre-filled with reagents, and these strips are sort of covered with a barcode which includes all the test relevant information, that is the lot specific calibration curve, the expiry date, and other product related information. Dr. Deepak talked about the SMC technology, and this is a unique technology available with this particular instrument, that is the sensotronic memorized calibration technology, a very unique technology. I will be just speaking about it in detail. So this leads to validation of each testing. So each test is validated before the result is generated, thus leading to a generation of high quality testing. So the pack size of a Allegria kit is 24 Allegria monotest strips are available in one pack size of a test, and it has definitely a very long expiry shelf life of around going up to 1 year to 1.5 years, so 12 to 18 months. So that is also of utility to the laboratory. And apart from a lab which is testing on this particular instrument, apart from the monotest strip, what it just requires extra is a wash buffer and a system fluid. So in a nutshell, it is taking out all the pain points, or rather all the additional consumables which are required for a manual ELISA testing. So any laboratory using this technology need not have additional reagents, additional pipettes, additional blotting papers, or other ancillary technology consumables which are required for ELISA testing. So it definitely brings down the costing of a ELISA test, and which is definitely of utility to any patient. So this is a combination of the test strip. So it's a 8 well strip in which the well number 1 to 4 are kind of empty wells which are used for sample dilution. And if you note well number 5, the well number 5 has an inbuilt control which is pre-filled. So this control is what is leading to a high quality validation or a high quality test result for each parameter, because this control is acting as a check for the reaction which is taking place. So this instrument follows the ELISA process of testing. So as we know, for any ELISA testing to happen, the integrity of reagents is quite important. So for whatever reason, if there is a deterioration of any kit or any reagent in a conventional ELISA testing, somehow the laboratories do not get to know, and somewhere or the other an inaccurate test report is released. Whereas in this particular system, if there is an improper storage or there is a deficiency in the storage conditions and leads to deterioration of reagents, it will lead to deterioration of the control itself. So the test will not proceed further. So that will lead to a stoppage of a generation of a inaccurate test result. So the result will not be generated, which definitely will prevent a wrong report being generated by any laboratory. Also, well number 6, 7, and 8 contain the conventional ELISA reagents which are pre-filled, that is the enzyme conjugate, the sample buffer, and the substrate. So adding to the reliability and validity of the test results, we have the Allegria quality control. So these are integrated Allegria reaction control on each monotest strip for validation of each analysis. These are test and lot specific, and this is what is present in well number 5. Also, apart from the strip controls, we have the Allegria positive and negative controls, which is sort of validates all the processes and the carousels which are present in the instrument. So basically there are two control checks which are present in this instrument: the strip control and the instrument control, which is the Allegria positive and negative control. So this is the Allegria instrument description, and this is Allegria 1, where you can load up to 30 samples in one go. The sample type simultaneously can be loaded are of the serum, the plasma, and stool. So no need to segregate serum and stool samples and process them differently or apart. You can in one go simultaneously load different mixtures of the serum, plasma, and stool samples. Conventional ELISA testing is done in the instrument itself, and the reading is done at the wavelength of 650 nanometers. So the SMC technology, what is unique to this is a sensortronic memorized calibration. So calibration is kind of a mandatory process which has to be followed by any laboratory, especially the laboratories which are using a manual ELISA technology for running the testing, the autoimmunity testing. And if there is a wrong calibration curve generated, the calibration process has to be repeated again, which is actually a pain point for the laboratorians, because that requires additional usage of consumables, reagents, and also increased time and increased manpower, which is then devoted to repetition of calibration. So to overcome that, this strip has a barcoded information which is called as sensortronic memorized calibration. So this strip is sealed with a special foil containing the barcode information, and the barcode information is passed directly to the system by the internal barcoding instrument reading on the instrument. So the instrument reads the information displayed on the barcode and process the samples, the calibration curves subsequently. So this is the example of what a barcode actually contains. So the barcode contains the product code specific or the assay code for that particular assay. It contains the which type of assay, the conjugate are you reading, which type of immunoglobulin class are you testing for that particular parameter, whether it's the IgG, IgM, or the IgA, or a screen. And it has the expiry date, it has a calibration curve, again, which are 4 points of calibration, which are already detailed in the strip, and the strip number. So the calculation of this results is done from the OD of the internal control, which is present on the strip and the patient sample, And then this OD is the index is calculated, and then this index value is read from the virtual calibration curve defined in the barcode. So, as I told you, the SNC technology has a 4-point calibration curve. The standard curve is a polynomial curve with 4-point calibration. And then the index value generated from the control and the sample is read as per the curve generated in the instrument. Also, this is how the testing is done, and I have already talked about this. So basically, this is in a nutshell is sort of displaying or telling about the process flow of the ELISA testing, which has been miniaturized into a strip form and leads to a standardized testing condition, leading to a highly reliable result. So this slide displays the ELISA process which is followed in the instrument, and all ELISA testing as per the convention is done by the instrument itself. So there is no need for any manual intervention. 30 tests per run, the flexibility offered by Allegria. So you can sort of choose 30 different parameters and get the results in 90 minutes. So that sort of enhances the TAT of a lab doing autoimmunity testing because of the flexibility offered. So you can have either 30 different assays or 130 different patients having each individual different assay. So you can mix and match different samples, different parameters, and you can get the results in 90 minutes. So this is the comparison of a fully automated Allegria 2 system versus a semi-automated Allegria 1 system. The difference in Allegria 2 over Allegria 1 is number one, the throughput. So 240 tests can be done in Allegria 2 in less than 8 hours. Allegria 1 does 90 tests. Time to result is less than 70 minutes in Allegria 2, whereas it is less than 100 minutes in Allegria 1. Test capacity is definitely more in Allegria 2. You can have 80 assays performed in one go compared to 30 assays in Allegria 1. So the customer, I mean, the laboratories which have a high workload for autoimmunity testing can definitely have a utility of having an Allegria 2 in their premises. Allegria 1 is more suitable for a low throughput lab or for hospital-based labs if they need to generate a high quality and a fast reporting for the clinicians. So this is the menu which is available on the Allegria systems, that is both the Allegria 2 and the Allegria 1 system. So for different diseases, the parameters are available, and we talk specifically of rheumatoid arthritis. We have the anti-CCP, high sensitive anti-MCP, which is the mutated citrulline-related vimentin, apart from the rheumatoid factors. Also for ANCA and vasculitis, high sensitive or the third generation PR3 testing is available apart from ANCA screen high sensitive, which encompasses testing again using a linker technology for both MPO and PR3, thus enhancing the sensitivity and specificity. For connective tissue disorders, as Dr. Deepak has already talked about, after a primary ANA screening, you need to do a reflex screening for the functional antibodies to various biomarkers to segregate which type of autoimmune disorder, connective tissue disorder the patient is having. So the biomarkers which can be tested on the Allegria system are available on both Allegria 1 and the Allegria 2 systems. I will just talk about the ANA detect in detail in my subsequent slides. Antiphospholipid syndromes, also cardiolipins and the beta-2 glycoprotein, which form the part of the guideline diagnosis and for both screening and diagnosis of the APS. In gastroenterology, Allegria system has the most comprehensive portfolio available for testing of all the autoimmune gastroenterology diseases. That includes all the autoimmune hepatitis syndromes, that is whether it is type 1 or the type 2. Also for inflammatory bowel diseases, calprotectin can be tested simultaneously with using the stool sample compared to the serum and along with serum and plasma samples. So a little bit in detail about the MCV, which is a unique proprietary marker which is available only on the Allegria system. It's a patented marker by Sebia, So what is MCV? It's a vimentin. It plays a central role in the pathogenesis of rheumatoid arthritis and in the formation of ACPAs, or what we say the citrullinated peptide antibodies. This is secreted by macrophages during inflammation and is detectable in the synovial tissue of the inflamed joints. And the structure of the MCV is such that it provides optimal exposure of the citrulline residues, enhancing the recognition by autoantibodies. So we already know, or rather, it is good to know that citrullination is an important part of any etiopathogenesis of rheumatoid arthritis, which leads to generation of autoantibodies. So the utility of having MCV over the current commercially available CCP1 or CCP2 or the CCP3 assays is that all the currently available CCP assays are detecting cross-reactive antibodies to filaggrin, whereas vimentin is a primary antigen which is present in the joint tissue. So detection of antibodies, or rather to mutated vimentin antibodies, has a better sensitivity and specificity compared to the cross-reacting antibodies which are detectable only by their reaction to filaggrin. So it's a highly sensitive, and these are the literature references for some of the utility points of MCV. It's a highly sensitive and specific marker for RA. It is suited for early diagnosis of rheumatoid arthritis, detectable even before the onset of symptoms. That is, even 24 months before the symptoms develop. It has a high correlation with disease activity, has a very good prognostic value because presence of MCV is indicative of a poor prognosis, or rather erosive course of RA. It is used for therapy monitoring more so. It acts as a biomarker to be used for testing the efficacy of the TNF alpha inhibitors in particular. So it's been labeled as the most powerful marker for diagnosis of rheumatoid arthritis, and definitely it has been patented and is present exclusively. It is being provided by Sebia on the Allegria system. So just to, in a nutshell, talk about the other utility points of the markers which are available with the Sebia system. So number one, the instrument itself or the technology, the Allegria Monotest technology, any test, any time. So no need of batching, improving the TAT of the autoimmunity testing. You are getting results within 100 minutes. So not even same day, even a half day reporting is possible. Anti-MCV is a unique proprietary marker for early rheumatoid arthritis detection. I've already elucidated that. ANA detect. So this is a sort of a complement to IFA testing. So this is an ELISA testing using for basically ANA detection. So this has a unique 26 antigens which are quoted in the ELISA well. So all the main nuclear and the cytoplasmic antigens which are detectable by immunofluorescence, the same antigens, lysate is quoted on the well for detection of ANAs. So it can be used as a complementary technique to IFA in case there is a strong pretest probability for a autoimmune disorder to be present and a IFA is negative, or other way around, it can also be used as a screening test for any autoimmune disorder, most so for SLE and the connective tissue disorders. Anti-CCP-HS and anti-PR3-HS, definitely, I told you they're high sensitive antigens. CCP is high sensitive, and here CCP also antigen which is present is the vimentin which has been used for testing. So therefore, the sensitivity is more. PR3 again is a very relevant marker for vasculitis and is a very relevant marker in case there is nephritis, vasculitis associated nephritis. So with the unique linker technology, which increases the sensitivity and specificity. So it is rather a third generation PR3 which is available on this platform. Most stable cardiolipids, stable because we know that cardiolipins are very unstable phospholipids. They have been very negatively charged. They have an inherent repulsion with any well on which it is coated. So with this Sebia system, we have the additional coating of the beta 2 glycoprotein 1 with anticardiolipin. So this adds to the better stabilization of the antigen on the well, thus reducing the false positives and the false negatives which are associated with the cardiolipin testing. Liver panel, definitely, as I enumerated, there is unique and complete panel for both autoimmune hepatitis 1 and 2. So apart from the atypical and anchors which are present, which are of helpful for autoimmune diagnosis. We have the LC1 and the LP1 antibodies which are available. So we have a full coverage of all the autoimmune hepatitis subtypes which are covered on this system. So to sort of end and summarize, Allegria has an extensive portfolio of more than 85 Allegria tests as of now, and it will be more than 110 by the year 2024 ends, ready to use barcoded test strips inclusive of test-specific reagents, standardized processing and analysis of serum, plasma, and stool samples in one go, no need of batching or separation of samples, flexible combination of Allegria Monotest, generation of comprehensive patient-oriented diagnostic profiles. So I would end the presentation here. Thank you for your patient listening.
Thank you, Dr. Siddhartha, for letting us know about Allegria and how it is, enhancing the diagnostic capabilities in the field of autoimmune diseases.
Thank you.
So now we move on to the panel discussion on emerging trends in the screening and diagnosis of autoimmune diseases. This panel gives us a chance to explore innovations further and discuss the practical and clinical implications, how newer technologies and approaches can be used. So my first question would be to Dr. Dhammanand, that what is the prevalence of autoimmune disease in India and how have you noticed the change, especially after COVID-19 pandemic?
The earlier good old days, autoimmune diseases are considered to be very rare in India. But we have realized with the increased awareness, the autoimmune diseases are very commonly diagnosed, and up to 3% of the population may have one or two autoimmune diseases. And if you include all the autoimmune diseases which involve various organs, then autoimmune diseases might be much more common than we believe. It can affect the population, and there is an inclination or the feeling that autoimmune diseases might be on the rise due to various factors like environmental issues, infections. Post COVID-19, there are definitely an increase in both classical and non-classical autoimmune diseases, and smoking, pollution, change in the diet pattern, and westernization of the diet and lifestyle might all contribute to increased incidence of autoimmune diseases we are seeing in the recent past. And also increased awareness amongst the doctors, and also increased availability of diagnostic technology also has contributed to increased recognition of these diseases.
Right. So my next question is to Dr. Shailja, that an autoimmune diseases are variable and complex in presentation. What kind of challenges do you face in determining testing strategies for the same?
Good evening, everybody. Now, see, when we talk about autoimmune diseases, it's basically an art and science where we should apply our clinical knowledge before ordering any clinical testing. Just, I have been listening to all the slide presentations and it was extensive. Many things which we didn't know. But even before we order a laboratory test, I feel a clinical thorough examination is very important. Just testing or just treatment with a ANA positive patient when clinically you don't feel that the patient has an autoimmune disease is not right. So when you are actually seeing a patient, you should know what this patient could have before ordering a panel of tests, whether laboratory or imaging study. So this is one most important factor which we should all learn. The challenges are where you're practicing, which type of hospital you're practicing, and which city you're practicing. Earlier, we used to get our autoantibodies maybe after 1 week, 1 month. Now we are getting it, like he said, we are getting it within 1 day, whether the ANA is positive or not, or whether the anti CCP is positive or not. So, first starting of treatment is very easy. You prevent not just mortality, morbidity, and deformities. So, that is very important. Also, you could also tell a patient whether he or she can have a disease probability. So these are very important things. It's not necessary in rheumatology that just one organ could be involved. A patient could present with multiple features, like a patient could present with a rash which may not be SLE. You might think it is SLE, but it could be just acne or anything like that. And just a borderline ANA positive does not mean that it is lupus. Like you were hearing about some patients who were just being treated for lupus when they did not have lupus. I mean, talking about SLE to a patient who does not have SLE is absolutely wrong. So whether you have diseases which are there in rheumat, they could be variable in their presentation, is very important. Multiple organs could be involved at the same time, and different places where you have to order which type of test is also important.
Right. And Dr. Dharmanand, do you consider ANA as a marker for screening the general population for autoimmune disorders?
ANA as a screening test to look for autoimmune disease in the general population is probably not a right approach. It is not a sensitive or a specific test like checking your lipids or blood sugar to make a diagnosis of diabetes. So these tests are used in the screening the population for much better long-term health. But problem with ANA is ANA can be positive in up to 5% of the population, and older the population, higher percentage of patients may have ANA positivity. So the prevalence of lupus and autoimmune diseases is not more than like 1 in 2000 or 1 in 5000 or sometimes 1 in 1 lakh. So there will be more ANA positive normal people than ANA positive autoimmune disease people in the population. So it is not useful to screen. But if it is a part of a screening protocol, somebody has done the test, and the patient doesn't have a disease, uh, that we have to deal with the uncertainties. It might indicate either a very early autoimmune disease, or it might indicate a single organ disease like thyroid autoimmune, Hashimoto's. Many of the celiac disease can also have ANA positivity in addition to the more specific antibodies. And even these can antinuclear antibodies. So it is better not to screen routinely, and it is only useful test if you have a pre-test probability of an autoimmune disease in your hand. You have a patient where you are strongly suspecting autoimmune disease, and if the patient has ANA as requested, then if it comes positive, then it is a very useful test. Then if it comes negative, then we have to start looking for an alternate explanation for this multi-system presentation. So I use ANA only in scenarios where a pre-test probability of autoimmune disease is high.
Correct. And Dr. Shelja, what titer of ANA by IFA do you consider positive, and what is your next course of action in such positive patients?
So now, when we have the ULAR guideline, which says a minimum ANA titer by immunofluorescence should be 1 is to 80 if you are considering even a connective tissue disease. Like Sir has already said, that it should be a probability. I mean, if the patient you feel has a connective tissue, should you screen for ANA? Now, if you have ANA immunofluorescence which is positive, you have ANA titers as previously told in ratios like 1 is to 40, 1 is to 80, 1 is to 160. So anything which is more than 1 is to 80, you can consider that it could be a probability of a connective tissue disease. Then you order for the ANA further studies, which you could either do by immunofluorescence or by ELISA. Now, what are the advantage and disadvantages? Like immunofluorescence, we used to consider it as a gold standard till now, or even maybe now, many of us still consider it as gold standard, because not just the uh, ratios, but also we know the intensity and the pattern on the ANA. So we could probably tell which diseases it is also involved, but it also requires good training methods. The substrates have to be standardized, so we are also using the ELISA or the various other methods which are coming. So these are important things. Now with newer techniques, you have to use it together. I mean, it's not just immunofluorescence only. You could use immunofluorescence followed by the ELISA techniques to give a better diagnosis. That is what I would suggest.
Right, right. And for Dr. Dhamanan, for screening, detection, and prognostication of rheumatoid arthritis, are you aware of other markers apart from the existing RA factor or anti-CCP, which have better sensitivity and specificity?
See, though we are aware of quite a few tests like anti-carbamyl B test, and as the previous speaker was telling, anti-MCV antibodies and RA33 antibody. There are quite a few other antibodies which are available, or technology is available, but they are not widely available in the market. So at this moment, they are not routinely done, and there is not enough data to use it on a routine basis in the clinic. So far, we are able to manage most of the patients with testing both rheumatoid factor and anti-CCP. But the latest anti-CCP technology, that anti-CCP3 or the latest version, is fairly specific and performs well in the clinic. And we don't do rheumatoid factor by IgM, IgA, or IgG. We don't routinely do. So we do only IgM rheumatoid factor in the clinic. And though in clinical studies, like IgA rheumatoid factor is associated with poor prognosis, but they are not still in the prime time to be used in the clinic on a routine basis.
Right. And my last question is to Dr. Shailja. Can you list some of the new treatment modalities for rheumatoid arthritis patients and how lab testing can help us in monitoring those patients?
Yeah, so now earlier we used to use just NSAIDs, that is the non-steroidal anti-inflammatory drugs and steroids. Now the concepts have totally changed. I mean, from 98 onwards, we have biologics entering the market. We have TNF alpha receptor blockers. Etanercept and infliximab were the first to come. Then we had rituximab, which came, abatacept, which has come. We have more and more newer injectables which are called as the biologics. Biosimilars have changed the market game totally. That is, they are the copies of the original biologicals, but that caused a lot of decrease in the cost price. Infliximab was available at a cost of 1 lakh rupees per injection. Now we can afford to give these patients at a cost of around 10,000 per dose. So now we have what is called as the oral JAK inhibitors. So that also we have the copies in the market, though not all the copies are very good, but they are extremely cost effective. I mean, the game changer market has been, in fact, the JAK inhibitors which are available to the Indian population. So it not only changes the prognosis of the patient, but you could treat the patients at a much earlier stage and at an affordable cost. We used to think before telling the patients whether you could take this injection. Now we can easily tell them. So first thing is cost effectiveness, safety. We have lot of tests which we could do to prevent infections. We could detect latent tuberculosis. We could ask them to do a DEXA scan before we start treatment. Use of steroids has significantly decreased. So I feel not just rheumatoid arthritis, but even connective tissue diseases diagnosis treatment has markedly changed after the newer drugs like Mofetil or tacrolimus, which are much cheaper than what it was originally launched in.
Right. So, with this note, I would like to conclude this session, and I want to thank each one of you for participating and sharing your expertise. Thank you very much.
Thank
Thank
you.
you. Thank you, everyone. Thank you, Dr. Manisha.
Thank you.